This is Dr. Howard Strassler with a Hints from Howard on Restorative Problem Solvers. Today I'll be talking about predictable crown and bridge repair with composite resin. Nothing lasts forever. Things wear out, things break. Teeth get worn with attrition. Porcelain, after many years of function, can fracture, or there might be a traumatic event that would cause porcelain to fracture. So fractured porcelain, what do we do with that circumstance? And on the upper right-hand screen, we can see a piece of porcelain that's fractured from a 3-unit fixed partial denture. So what do? Well, the first thing is we have to tell the patient the best thing to do is to remake the case, to take off the existing restoration, redefine the preparation, make a new impression, a new provisional restoration, send it to the laboratory, and fabricate a new restoration. When possible, we can smooth and reshape. In the anterior region, for large fractures, that may not be possible, but small chips of porcelain in the posterior can certainly be smoothed out with a fine diamond, a stone, and then a rubber abrasive. But when all else fails, when there's an emergency or the patient for financial reasons can't afford to remake the case, or perhaps they remember what it was like having it done the first time, the preparations, the anesthesia, the cord packing, the impression, the try-in, the adjustments, the temps coming off, the temps breaking, and they want to know, is there something else you can do? Absolutely something else. And in those instances, we can offer an adhesive repair, but we need to be very selective in our treatment planning for these repairs. And so when we're treatment planning anterior fractures, we may take a different view than when we look at a posterior fracture on a single crown. Because a single crown, perhaps remaking it is the best. In fact, the guidelines for treatment planning, based upon our best evidence and from case reports, is anterior repairs are the most predictable. Posterior fractures, the most difficult to repair. Fixed partial dentures give us an option to repair, but when they're in the anterior. And single crowns replaces the best option, although you may repair as an emergency treatment until the patient can be scheduled for a remake of the crown. So the basis for porcelain repair is bonded porcelain veneers, and the chemistry of composite resins. We can get adhesion between the interface. In fact, we see clinical studies with porcelain veneers of over 20 years of success. So let's look at the materials and techniques for predictable repairs. Our focus will be the treatment of porcelain and the treatment of the metal. In fact, when you see a fracture, you need to prepare that surface. You need to make the surface fracture 2 to 3 times larger to have more bonding surface. You'll use a diamond in a high-speed handpiece with air-water spray to remove the porcelain glaze. We can air abrade the porcelain using a microabrasion unit, a microetcher from a variety of different manufacturers. We can treat the porcelain as well with hydrofluoric acid etching, or we can use an acidulated phosphate fluoride. All these will etch an unglazed porcelain surface, making it microscopically rough. We can then treat the porcelain with a silane porcelain primer, where the porcelain primer will allow the composite to better wet the surface and to have a chemical bond. Some of the newer universal adhesives replace the use of silane. If we have exposed metal, we can once again air abrade that metal, or create undercuts in the metal in order to have a mechanical locking of the composite to the metal framework. In some cases, penetrate into the dentin as long as we don't affect the structural integrity of the crown. We can also use metal primers and adhesive. There are a variety of them on the market. The best metal bonding agent to base metal, and we're talking about really repairs to base metal, is C&B Metabond from Parkel. Although there are zirconia, alumina, metal primers from a variety of different manufacturers, to include Bisco, to include GC, to include Ivoclar. But when we have exposed metal, we need to place an opaquer so we can mask that gray metal. Some of the best opaquers are composite resin materials that are extremely opaque. And my favorites is Color Plus from Kerr, using either the A1 or the A3 opaquer, basically creating a dent and shade. In thicknesses of 1/10 of a millimeter, we can mask out the metal, as we see here for the case of the canine. So let's take a look at a case. A 3-month-old fixed partial denture. The porcelain fractured because the patient fell and kissed the concrete. The bridge was made 3 months ago. The patient used dental insurance. The insurance won't pay to have it remade. Patient wants to know, can something else be done? They can't afford to have it remade at the current time. So we talk about a repair, and we tell them the durability of the repair could be 6 months, could be 2 years, could be 5 years. We really don't know. It depends upon the bite. It depends upon their function. Gosh, they could fall again or hit it in a certain way that it would fracture. But we can attempt to repair. And that the fee for this repair would be the same as if they were having a class 4 composite resin placed. So we go in and we evaluate the occlusion. If occlusion is going to come into a factor, then we need to adjust the opposing teeth. And we tell the patient this is to enhance the durability. We prepare the surface that fractured with a diamond, lots of water spray, medium grit diamond, and notice we're 2/3 down the facial surface. We're on the lingual surface and preparing the metal. We've created surface area to bond to, and it makes the fracture look a lot worse. We then have a choice for porcelain treatment. We can either air abrade the porcelain, or we can etch with hydrofluoric acid. And from the scanning electron micrographs you see in front of you, both give us a microscopically roughened surface that we can bond to. In fact, the air abrasion can also air abrade the metal surface that we'll be bonding to, although our primary bonding will be to the porcelain. For this case, we've made the decision to use a hydrofluoric acid etch. We've put a soft tissue resin barrier to protect the gingiva from the hydrofluoric acid etching. The patient's wearing protective glasses. We want to make sure that we're careful when we use it. We apply this gel etchant, a 9.5% buffered porcelain etch, to the porcelain surface for 2 minutes. I then use a high velocity evacuator to suction off the etchant, not rinse it into the patient's mouth. I remove the last vestiges of the hydrofluoric acid etch with an air-water syringe with my high velocity evacuation tip. I then dry the surface. The dried surface of the etched porcelain looks somewhat irregular, and that's because it was a stacked porcelain, a feldspathic porcelain, and it doesn't have a uniform density. I now go in and I paint in my porcelain primer, my silane. As I said earlier, I could have used a universal adhesive like Scotch Bond Universal or Prime and Bond Elect to this surface and eliminated the use of a silane. I paint the silane on, 30 seconds, air dry, and the porcelain looks the same. The silane is a microscopic coating that changes the surface area of the ceramic and allows resin to chemically adhere to that substrate. I place a metal primer on the lingual surface, and now I'm ready to place my composite. I paint on an adhesive resin, and if I use Scotch Bond Universal or Prime and Bond Elect, I wouldn't need to do anything additional. In this case, I'm using a 5th generation adhesive to this surface. I'm air thinning it with some air, I'm air evaporating off the solvent, and then I can light cure it. When I light cure it, the light has to cover the entire facial surface. Know your light. 10 seconds. Make sure I'm covering the entire surface. The light is very close. I then go in and place my nanohybrid composite, the same way I would for restoring a class 4. I'm placing the composite, I'm sculpting it on the surfaces. I'm going to have very minimal excess to work with. After I've placed my composite and it's where I want, I'm then going to take my curing light and I'll light cure for 10 to 20 seconds depending upon the light irradiance of the unit and the light tip diameter. After light curing, I'm ready to finish and polish that composite. I go in with discs to marginate and to shape, and to get the incisal edge to the length and shape that I desire. I then go in and polish it, and in this case I'm using an enhanced finisher from Dense Bicaulk, and then polishing it up with a diamond abrasive, a luminescence paste from Premier, and then a goat's hair brush from Ultradent to polish up this nano hybrid to a porcelain-like glaze. I remove my soft tissue barrier, I check the occlusion, and I give the patient a mirror to admire what we've done, to look at it, to see that we've done a repair. And so we've created a repair that's going to be very durable. We make appropriate adjustments based upon occlusion, and we tell the patient, we expect this resin repair to last anywhere from 6 months to 5 years. We don't know how long it'll last, but they need to be very wary what they do. We don't want them to grind on it. We don't want them to bite on a fork. But they can eat everything they normally eat. And so we look at what the patient came in with originally when they fractured the tooth, when they fractured the pontic of the bridge, and what we restored it to. We've got a very nice result. This has been Dr. Howard Strassler talking about predictable crown and bridge repair with composite resin.